Good evening and welcome to this panel. And it's really talking about health, which is something that we've all experienced. And we also see the crisis that the Indian Health Services faces. Without any major introduction to the session, I'd like to invite my panelists, Sonal Desai, Shakti Selvaraj, Dr. Kapoor, and Oman Korean. What we thought we'd do is actually Oman sent some talking points and I kind of mulled over it, and I thought that maybe we can begin with a couple of larger questions and then come down to some of the more recent and glaring challenges that this health sector faces in India. Clearly, we all know that a lot of the debate has been on financing health services, and especially public financing of health services, and the fact that India has a very high out-of-pocket expenditure on private health services. That is, a large section of the population is accessing private health services. And I would invite Shakti to really open this panel with an overview of what are the patterns of health financing, what is the kind of crisis, and looking specifically at the challenges of access to medicine. Shakti?
You asked me a question, I will reply.
All right. Thank you, Professor Baru, and evening, everyone. In India, we know that India has really made rapid and remarkable progress in terms of achieving health goals, other in terms of enhancing your life expectancy, reducing IMR and MMR quite significant in the last at least about 10 years or so. We all know that India, of course, is a medical tourist destination. India is also can boast itself as of being the global pharmacy. We produce about $250,000 crore worth of rupees of medicines and export to about 190 countries around the world. And yet, we face serious challenges. Serious challenges in terms of epidemiological transition that's happening across the country, but most strikingly the southern part of the country in terms of rising non-communicable disease. And two, that's the epidemiological part of it. Two, health system challenges. Now, I'm going to focus on two specific issues. One around the financing, the current challenges that the country faces in terms of healthcare financing, and then access to medicine. In terms of healthcare financing, we know that the Sustainable Development Goal, for instance, if you look at target 3.8, calls for providing financial risk protection. So one of the, if you look at universal health coverage has three dimensions: the population coverage, the service coverage, and then the cost coverage. So financial risk protection is all about providing this cost coverage, reduction essentially in terms of households out-of-pocket payment. But before I talk about the real problem of, persisting problem of households out-of-pocket payment, what really led to that high households out-of-pocket payment? Over the years, if you look at India's story in terms of healthcare financing, beginning from the 1950s, we've had low, persistent under-investment in health sector. Currently, India spends about 4% of its GDP on healthcare. The public spending is about 1% of GDP. Probably if you rank countries around the world, India would be about 185th out of 190 countries in terms of public spending. And as a result, your households out-of-pocket payment is extremely high, about 70%. If you look at, as I said, out of the 4% of GDP that we spend, 70% actually comes from households out-of-pocket. That's inefficient and iniquitous. We all know that. In terms of public spending, what's really causing the current problem? We know that India spends only about 1% in terms of public spending. If you put together both center and states together, that's about 1%. So the central government share is about 1/3 and 2/3 contributed by the states. And that's the current spending. But last 3 years, last 3 to 4 years, the public spending, there's a huge challenge in terms of public spending. 2005 was a major deviation that India took in terms of financing of healthcare. Till about 2005, from 1950, we've had what is called every government spending used to be routed through the treasury. So you used to have treasury route spending. Beginning from 2005, after NHM came into being, NRHM and now NHM came into being, we've had some bit of flexibility in terms of funding. We used to have society route, but that's gone now, beginning from 2014, because of the 14th Finance Commission recommendation. Two things happened. One, on the one hand, the states have got more money through tax devolution from about 32 to 42%. But on the other hand, the size of the NHM centrally sponsored schemes have gone down, and that's one challenge. Two, states' own share has reduced from about 75 to about 60, and it's likely to go down to about 50-50. That's first set of challenges. The second set of challenges, now the flexibility that we had, we've lost that flexibility. The health system has lost that flexibility. We're going back to the treasury route. That's a major problem that I see. The other issue is about insurance. Now, India has a very interesting set of insurance schemes. These are government-funded health insurance schemes. That's true of the National Health Insurance, the RSBY, and then several states has its own state-based health insurance schemes. Now, a huge fragmentation of financing has happened beginning from 2007, 8 starting from RSBI and several other state government-funded insurance program. Because of the fragmentation, a huge problem with both in terms of efficiency of resource use. So those are issues that currently that the country is facing, both at the central as well as at the state level. As I said, in terms of households out-of-pocket payment, because the government is spending low, for almost 20-25 years, the percentage of share of households out-of-pocket payment has gone up and up. Now it's about 68% of the total health spending in the country. As a result, 60 million people are being impoverished annually because people have to pay out-of-pocket payment. About 16% of people who pay out-of-pocket are incurring what is called catastrophic payment. That's not any, not a very desirable outcome in a sense. The last thing is, of course, there are potential solutions. I'll come back to this. Probably I'll stop there, and if there are questions about access to medicine, I'll add later.
Actually, we will have time. We're making the panel speakers speak briefly, and we'll pick these issues up again in the discussion. I think the two very important issues that Shakti has raised. One, that health is ultimately a state subject. So therefore, you do find a lot of variation in the way in which not only financing is done, but also the robustness of public systems, as well as the growth of markets. So I thought it would sort of lead very well to the question of inequities, Sonal. And I thought that it may be useful to highlight some of those issues.
I'm going to try and highlight a couple of different issues. One is that we need to think systemically, and the second is that we need to think about nuts and bolts, okay, rather than sort of high-level conversation around issues of health. We have a number of very strange paradoxes that we might that are worth highlighting. Okay. For example, India undertook one of the largest conditional cash transfer programs, Janani Suraksha Yojana, which has increased the hospital delivery rates phenomenally. However, neither maternal mortality rate nor neonatal mortality rates have declined substantially, at least based on some of the quantitative analysis that has been done. part of it is, I think, that increase in hospital births was, there was not enough investment in hospitals, so that hospitals have been extremely overcrowded, and hospital-based infections have been quite rampant. The cesarean rates have gone up. So in some sense, I think when we make changes in one part of the system, we need to think about what are the spillover effects somewhere else. Another example that is really striking is that India passed the National Food Security Act in 2013. National Food Security Act basically is practically free distribution of rice and wheat. Okay? Now, actually we know that India is going through a rise in non-communicable diseases. There is plenty of research in US, UK and Australia of South Asians who are prone to high risks of diabetes, high blood pressure and cardiac arrest. We also, now we don't quite know what causes it. Are there genetic factors or are there dietary factors? There is at least sufficient literature to tell us that increased consumption of carbohydrates can lead to some of these conditions. And yet, all our food distribution system focuses on cereal distribution, carbohydrates, and not sufficient focus on anything else. So in some sense, I think it's that sort of, we do one thing and what are its impact on something else, we don't think about sufficiently. Healthcare financing is definitely an issue, but we might want to think about why is it that some of these costs are rising, okay? Because the healthcare services are not improving tremendously, it's just the cost that's rising. Well, one of the things that we do know is that increasingly there are things like antibiotics in India are very easy to get. Antibiotic resistance is developing pretty fast. And treating tuberculosis case with multi-drug kind of therapies is much more expensive than through more simpler therapies. And yet we have no efforts that are being made to control the proliferation of antibiotics or actually just access to drugs at will. You know, you could walk into today any pharmacy and get any drug that you want, including psychotropic drugs, any kind of antibiotics that we want. There is very little discussion about what we might do to be able to control some of this proliferation of drugs on the market. So I think in some sense what we need to think about is, first, are there actions that we take which are harmful over a longer run? And that's actually the first thing to control, that at least that's something you can control immediately. The second part of it is to think about when we are sort of developing systems, can we think broadly and look 20 years in advance rather than just today and deal with issues that might, or threats that might be emerging over time? Okay. And a third part of it is in some sense being rational about what we are going to be investing in. Okay, there's something, you know, health is something that tugs at your heartstring. Okay? And hence, one sort of wants to think about investing in all aspects of healthcare needs. But sort of prioritizing is essential, at least as far as government investments are concerned. So to think through where we might, what our priorities might be and where we might invest with the greatest bang for the buck would be something that is worth thinking about. I want to go back for a second on the antibiotics. You know, India is the largest consumer of antibiotics today. Per person consumption of antibiotics in India is about 1.5 times in US or in China. And it's all because we just go and buy it in the shop as we wish. Okay? So in some sense, sort of just thinking through what drugs should be easily available, what should be made available with difficulty, how do we teach people what to do. On non-communicable diseases also, I think that one thing to think about is that it's very easy to talk about NCD as a major burden, but how on earth are we going to deal with it? Okay? And one of the biggest thing is really that to think in terms of screening rather than treatment. Okay? Blood pressure is one of the silent killers. Most people don't know that they have high blood pressure. Most people don't know that they have diabetes. The way for people to know is really through some sort of diagnostic testing. And diagnostic testing is something that we haven't invested in very much. And yet, we are very fortunate to live in an era where technological advances make it much easier to actually develop better screening strategies at the grassroots and village level. India has historically done well when it deals with issues on a campaign mode. You know, polio vaccination is one of the best examples. Okay? So in some sense, thinking about screening in campaign mode would make sense. Even things like undernutrition, really one of the biggest things is that parents don't know that their child is malnourished. Okay? Along with a polio camp, could we do, along with polio camps, could we have something where we also have people weighing and measuring their children and print out those reports and give it to the parents so that they have some sense that their children are lagging behind and falling behind. So, you know, thinking of common sense, sensible strategies that fit within our historic patterns of systemic administration, okay, would make sense.
Thank you very much. And I think one of the great challenges in which you have raised, you spoke about non-communicable diseases. It's true for communicable diseases as well, whether you look at tuberculosis, malaria. But what we are also moving into, and which I will request Sushma Kapoor to speak about, is what are the kinds of systems we need in place to really tackle this problem. Sonal talked about primary level screening. So who's going to do the primary level screening? Is the market going to do it, or do we really need a robust public system? So that's one question. But it is also the case we have many, many ironies in the Indian health system. You have global players like Apollo, who seem to be the leaders of global health and symbols of global health. And then we have primary health services which don't function at all. So you're really dealing with a system which is extremely chaotic. And Sushma Kapoor, I'd like you to sort of throw some insights on this.
Thank you so much, Rama. And good evening, everybody. It's such a pleasure to be here. Yes, we've already talked, all the speakers and our chair has talked about the ironies and the dichotomies that we are living with. We are a country which has possibly the highest medical tourism. We produce our own drugs, but on the other hand, there is vast numbers of people who do not have access to healthcare in even its most basic form. So the issue I was wanted to raise was that what we need in this country primarily is a comprehensive primary care system. Yes, I think Shakti mentioned that in 2005, under NHM, the government did a lot of investment. We created a large number of sub-centers and primary healthcare centers, etc. But I would like to focus on a couple of issues there. One is that of design, the other is of provisioning. But to start with, what do we mean by a comprehensive primary health care system? It's characterized by high accessibility, and that we all know is a problem here. We should have, and I think we will talk about technology later, that we should have technological resources to diagnose, as Sonali said, diagnose and screen and the health problems, and that these primary health centers or the care system are the gatekeepers, as happens in a lot of other countries, that they are the compulsory gatekeepers and they are the ones who refer. They are responsible for the referral to secondary and tertiary care hospitals. And of course, most importantly, that we have trained primary care practitioners. And we've seen that these are the fundamental attributes that in countries where we have a very successful primary health system, and for example, Spain, Thailand, Kyrgyzstan, Colombia, they have very successfully rationalized their hospital care through implementing the referral management and for disincentives, in fact, for going to the tertiary and the primary, because that costs more money. And if we were able to diagnose and screen and provide the primary sort of care at this primary care center level, then that's in fact, it's beneficial for all stakeholders. It's beneficial not just for your client, the purchaser, but for the provider, because the cost of setting up secondary and tertiary healthcare facilities is far higher, and it's also beneficial for the insurer. So this, of course, we are talking about providing it to the majority, I won't even say majority, but to everybody in the country. And then, of course, you do need the secondary level of prevention through referral services. But in the Indian context, we know that this is not happening, and the primary, the problems lie, as I said earlier, in both the design and in the provisioning. Now, if I was to talk about the design, what is it? What are the biggest challenges? We are witnessing, as other speakers have already said, a rising burden of non-communicable diseases, and the public health system currently is largely geared to address maternal and child health. You know, the focus since the MDGs has been on maternal and child health, and we've already said that we brought down infant mortality and maternal mortality rates. Not enough, but yes, we have succeeded in that. But then we are seeing, on the other hand, a rapid rise in other diseases, the cardiovascular diseases, cancers, chronic respiratory diseases, diabetes, as has been said. Now, all of this is accounting for nearly 60% of all deaths. So in some senses, higher than maternal mortality and prenatal and nutritional deaths due to nutritional deficiencies. So again, what I want to emphasize is that the current health system is not equipped, not designed to deal with these emerging health needs. And so there's a lack of focus on preventive health, and that's where your 95% of hospital cases can be treated, as evidence has shown, data shows, can be treated at the primary health level. The other thing that I wanted to quickly focus on is that today we have not today, for the last decade and more, we've had a split between the vertically driven programs, malaria, TB, HIV, which is funded by the center. And then, of course, you have the 4-tier public health system, which is the cost of which is shared by the state and the government, and of course, as we all know, it is underfunded. So there is this, I mean, the vertical driven programs have their own hierarchies, and there's a kind of a sort of not a coming together of the two. And because of this, I'll take one more minute, because of this weak design that we were talking about, the provision then becomes very, very limited. And again, the problem in terms of delivery of health services is lack of accountability, lack of regulation, and that affects your health outcomes. The public health servants are more concerned about the inputs rather than the outcomes. So there is a significant shortfall. Again, we've talked about it. We can talk more about it in infrastructure, human resources, and most of all, quality of services. We can talk further about that.
Thank you very much. I think the 3 panelists have really addressed some of the challenges of the health system in India. I think the issue of a mixed economy in medical care is a huge challenge, because we have a large private sector which is unregulated, and that has fueled costs and you have a weak public system which is not able to be really as responsive. So I think one of the things I want to do and request women to come in is to not just look at health as a medical issue. And I think we've been focusing on health services, correctly so. It's one of the very important inputs. But if you go beyond the boundaries of medical care and health services, we get into a series of issues which you alluded to, Sonal, which is about undernutrition and overnutrition. That is another way in which we can look at health problems in India. So when you see both undernutrition and overnutrition come to play, and the diseases that they are likely to produce, and the continuum of undernutrition and overnutrition, contrary to what we believe, that NCDs are, you know, lifestyle diseases of the rich, we now know that there's a downward shift where you're seeing undernutrition on an intergenerational transfer of undernutrition actually also in the life course produces non-communicable diseases. So we are really dealing with an extremely complex issue, and I request women to sort of speak on that.
Thank you so very much, Professor Baru. I'm deeply honored and humbled to be part of this panel. Talking last, the primary problem that I face is most of the stuff that I came prepared with is already discussed. So I'll try to list out a few challenges that I see as India moves towards a healthier future, and probably get back to these points in detail during the discussions.
Yeah.
So in India's case, people are pretty familiar with the failings of the system, the health system. So it is easy to assume that our future challenges are going to be somewhat the same ones that we have been faced with in the past. That is not the case. What is often not discussed is a fact that right now more people in India are overweight than the number of people who are underweight. The NFHS, which released the numbers, India numbers earlier this year, estimates the number of overweight people to around 19% of the population, but that remains a huge underestimate, because it uses a cutoff of 25 kg per meter square BMI, which is the global standard. So there is a consensus now that Asians have a higher percentage of body fat, and they are vulnerable to NCDs, non-communicable diseases, at a lower BMI. So the WHO has suggested a cutoff of 23. So when we apply, NFHS has been using 25 as a cutoff for the last 3 rounds. So they have used it again and reached this 20% overweight estimate. But if we were to use 23, there will be a huge jump. For example, there was a study by ADB which was released last month. They did this exercise using a slightly older data set for Kerala, and Kerala's overweight population with the 25 cutoff is 30%, and when we use the 23 cutoff, it jumped to 48%. 48% of the working or reproductive age group population in Kerala is overweight. So as we speak, a huge number of India's population are overweight, and this nutritional transition and the epidemiological transition are interacting at a very at every level of the spectrum. The undernutrition contributes to the communicable disease burden, and overnutrition contributes to the NCD burden, and it throws up a very complex health policy issue, and these twin double burdens are going to be the biggest health policy challenge for India to face in the next coming decades. The Global Burden of Disease Study 2015 had ranked for India the major risk factors to attributable burden of disease for the years 1990 to 2015. Of the 10 top risk factors in India, 6 were linked to nutrition. 6 out of 10 risk factors in India, and the 7th one was unsafe water. So, I mean, only 3 are unrelated to nutrition in a way. The proportion of NCDs also keep increasing, even in the so-called lagging states where NCD, the so-called MDG conditions, that is maternal child infectious disease burden is still high. There also the NCD burden is increasing at an alarming rate. So even in the lagging states, the disease burden, the composition of the disease burden is shifting very fast. For example, I mean the regional differences are very stark. In UP, the so-called MDG conditions still cause 42% of the deaths, while in Kerala it is just 6% of the deaths which are caused by the MDG conditions. In Kerala, 70% of all the deaths are caused by NCDs, non-communicable diseases. In UP, the non-communicable disease burden has actually has increased considerably, but it is still at 42. So, as Dr. Kapoor mentioned, our healthcare delivery system is still geared towards the previous set of challenges, that is the MDG conditions. It is said that the National Health Policy acknowledges that all the disease conditions for which national programs provide universal coverage account for less than 10% of the mortality burden and less than 15% of the morbidity burden in the country. So, fast changing disease profile is going to be a huge challenge for India in the decades to come, but it is also erroneous to assume that infectious diseases are the diseases of the poor alone and NCDs are for the richer groups. It is shown in recent research studies that there are a considerable number of households in India where the child may be undernourished, the mother will be overnourished. I mean, it is more than 10% of all the households in India. So, and another complexity that adds on to this situation is, if you are undernourished as a kid, your chances of absorbing extra nutrition future when your economic condition improves, it increases and you are more vulnerable to NCDs. So that leads to the situation of undernourishment and overnourishment coexisting in the single household. So the National Health Policy, which was released recently, it focuses on a shift towards to comprehensive primary health care, which is a positive sign. But if in the name of comprehensive primary health care, if what we are going to do is to add on to the existing burden of the frontline workers, it is not going to gain anything. I mean, India is not going to gain anything out of it, because the frontline workers, they are the ones who do most of the work. They are severely overburdened. Any new vertical program that the government introduces, the burden of the frontline workers increases. So, finding ways of addressing these challenges in a comprehensive way is going to be the major challenge. And since we have already mentioned financing, I wouldn't go there, but I'll just add that the debate around financing in India is unnecessarily polarized. I mean, it is made out to be an insurance versus provisioning one, and we put a lot of emphasis on out-of-pocket expenditure, private out-of-pocket expenditure. It is not very clear how useful that is without tempering it with other parameters, because Kerala is considered to be the strongest, one among the strongest public healthcare delivery systems. Kerala also happens to have the highest private out-of-pocket spending. Kerala has the highest reported level of morbidity. And despite a public sector which is strong, Kerala's sick population prefers the private sector. So I mean, we'll have to have a two-pronged approach, where the poor will have to depend on a very strong public care delivery system, and the richer sessions will have to be charged, and a bigger pool of health financing mechanism should, I mean, through an open process, fill the gaps within the public healthcare delivery system. So this is what I think. I'll stop here. I'll just add 2-3 more things, broad questions, because I feel these are pressing, because just adding funding may not really answer the question, because as of last year, Accountability Initiative brought out a study which showed that half of all the money that went to certain states came back from the health system. There is a severe absorption capacity issue. So money is not everything. Second, even if we solve the human resource gaps, there are complex issues at play. As Professor Desai's very insightful IHDS data set recently showed us, 25% of India's population, they admit that they practice untouchability. So many of these people, and the numbers are higher in the rural side, many of these are health functionaries who work at the grassroots. So overcoming these are going to be a very complex challenge. And lastly, we have to make sure that health also becomes a sector which offers decent employment. It is very well known that the private sector exploits the nurses, often junior doctors who don't have the negotiating power, but it is often not discussed how the public sector also exploits. We get the stuff done by the frontline workers, and we prefer not to pay them by calling them volunteers. Ashas have been contributing the most to the improvement of our institutional delivery numbers, but they are paid a pittance and their jobs are not secure. So this is not, certainly this is not the way to go in the next few decades. Thank you so very much. I'm really sorry for taking too much of your time.
I am not going to summarize the discussion. I think the speakers have covered the range of angst that faces the health services. But I just want to open this discussion with a provocative statement. I mean, I think we on this panel would want a comprehensive health system. But I think we also need to recognize that majority of the states that have followed a model of an insurance system. So have we really medicalized the Indian health system? Have we moved very far away from the idea of a comprehensive health system, which in a sense all public health people would want and dream of? So I'm just going to leave this question open and all the other questions that have come up from the presentations, and I hope you will all have many questions for us.
Thank you for those presentations. As you can well imagine, I am a lawyer, so there's only so much I know about healthcare. But there are two questions that I would like to ask. One is the one that Ms. Desai brought up regarding the antibiotic and how the whole population is becoming more resistant. I think that cuts across the urban-rural divide. And I think it's very true, because I think there's a large section of urban society that goes straight to a pharmacy instead of going to a doctor, and the pharmacist just gives them some antibiotic which takes care of their fever immediately, and then they are back to because they cannot afford to lose a single day of work. They are the unorganized labor or whatever in the urban area. So obviously legislation and enforcement machinery is not working in that area. So what would you what do you think will address that issue? My second question is to all the panelists. What about geriatric care? I mean, I think that's hugely. I keep joking with my husband, and I keep telling him, if you predecease me, I think I will shift to Sweden, because apparently they have the best old age health care. So that's a family joke we have, but it's a very frightening thought. I mean, okay, those of us who have the ability to protect our older aged days alone or in the family, because we're all now nuclear families. But the point I'm trying to make is, I think geriatric care in this country is abysmal. And it's a very frightening thing, because we're all going to get old someday. And if you're not already there. And the point is, how do you think that issue can be addressed? Thank you.
Ma'am, can I just add to that question, the same question? I just wanted to add one additional layer. So I think this is extremely important in the next 15 years or so, as we reach the peak of our youth bulge. That is 650 million under the age of 30 or some number like that. We are also going to start moving towards a 250 million 60 plus population. And one is end of life healthcare, which is very different to what we are talking about, nutrition and maternal healthcare systems and that debate. So where do you position our preparedness for the 250 or 300 million 60 plus population that is going to hit us in the next 15 years? Europe had 200 years to prepare for it. We have, even as we grow young, we are growing older. So I think that's the shock.
Actually, I have a question, because I don't know the answer of that, and I'm sure your experts will be able to say. You know, on the one hand, we are talking about decentralization, giving powers to states. But on the other hand, states are doing very badly. Some states are totally indifferent. You know, recently I had an opportunity to move in some states and found that state government is not willing to add much to the pension or insurance that is to be given to workers. And in that case, the insurance doesn't make much sense. You know, the premium that state is putting premium. So what do? Do we give it to the states, or do we give it to the center? What is the way of organizing this? One thing. And secondly, not the center is extremely committed, but at least relative commitment would be perhaps higher at the central level than state level.
Let me take the question on antibiotics. It's a very thorny question. You know, I mean, it would be easy to say we must regulate everything. Frankly, none of the regulations in India have ever worked, right? And so, at some level, let's be realistic. And I think some things, we may need to have a tiered administration of drugs. The first thing is that most people who are sick, okay, just go to a pharmacist and are given certain things. Okay? Think about what are the common illnesses, what are the common medications we would like to prescribe. Okay? Make good charts and put it up on all pharmacies. Okay? If you have a stomach upset, you don't have to start with antibiotics right away. You might be able to take antidiarrheal medication. Okay? So for common things, let's try to avoid antibiotics by educating people. Okay? On antibiotics front, perhaps one way to deal would be to say that certain things are available through common pharmacies, and certain things are very hard to, you know, things which we are increasingly seeing as, there are points at which there may be only 3 drugs that are really workable on TB given the resistance that has already spread. Those 3 drugs should not be made available through normal pharmacies. Okay? So in some ways, sort of looking at what do people take, why do they take it, and how do we control it, and go for the high value controls would make sense.
Just 2 quick points about the geriatric care that you talked about, and then questions supplemented from the other gentlemen. I think 2 points certainly is important that I think one is the primary care. So everything boils down to primary care prevention. Unless we set our primary care simple and straight, the broken system will never get resolved. The other point is about the risk factor reduction. A huge risk factor, tobacco consumption, alcohol consumption, and so on and so forth. All that, again, we need a lot of emphasis and focus on risk factor reduction. I think that's the key message in terms of helping people when they move up 60 and above, which will have a lot of implication in terms of not only good health outcome indicators, but also reduce the cost. The point about whether state or center in terms of funding, if you look at the current pattern, it's about 1/3, 2/3. States' own resources about 2/3, centers funds about 1/3. Now, if you look at the current regime, and also need to look at the last, people argue from very influential quarters that we don't have the fiscal width to accelerate public spending. I beg to differ. If you look at last 15, 20 years, the tax GDP ratio has gone up from about 12 to about 18% now, about a little over 18% now. So both revenue buoyancy as a result, tax buoyancy has accelerated sharply, very significantly. And we have a formal sector which is growing. Of course, we are also stepping into what is called a GST regime, where you expect revenue buoyancy to go up. One, of course, you're widening the tax net, and the governance is also going to improve as a result of GST. And if that happens, the possibility of both the center and states getting more revenue is possible. Add to that, given the Finance Commission recommendation, the states are now getting more money from the center as a tax devolution, from about 32 to 42%. The point is, how many states spend more as a result of additional revenue that they've got? Unfortunately, except few states, health is never a priority, never been a priority. That's the fact of life. But having said that, this center cannot abdicate its responsibility. As a nation, if we want to attain, we have passed MDG goals. Now, about at least 13 years to go to SDG goals. It's again a challenging task to achieve those goals. The center still maintains, remember, ultimately whatever said and done, states has its own fiscal limitation. So center still has a lot of fiscal width. It can still, and it needs to spend on health.
More with Shakti that primary health care is the need and is the answer possibly. But some very interesting questions were raised about geriatric care. I don't have an answer. But I want to add something there, and that's mental health issues. I think that's also a very growing problem in our country, which we are still not recognizing and acknowledging. And we can add that to all the other disease burden that we talked about. About the state I think Uman talked about the absorption capacity. It's a willingness, how much you want to focus on health, but also how much you can spend. They're both interrelated, but that's really where it sort of, hinges very often that, you know, money is not spent and money, therefore the next year the money is not given in similar proportions to the state. So yeah, we have a lot of issues that we need to focus on, and it's almost sort of the menu of challenges is very, very disheartening sometimes for those of us who have been working on it for years and years as to how this can be fixed. I mean, we are a signatory to the SDGs, which talks about, of course, universal health coverage. The new WHO DG, Dr. Ted Rose, I heard him the other day say, all roads should lead to universal health coverage, and there should be a social movement. And I think that's what we need in this country, a social movement, because far too long I think we have just borne the disparities and the inequities in this country.
I'll just make three responses. One to the comment about the geriatric care. I mean, it's a terrible thing to say, but I think that I mean, the old population of India is going to be on their own, because the past 2 or 3 decades, the health activists and the health researchers have been trying to sell the idea to different governments that human security, quality of the working population is bad, you have to improve it. Invest in the health sector to improve your working population's quality and efficiency. The respective governments haven't really bought that argument. I don't see this, this policy, I mean, the investment shift to old age care, which will need considerable resources happening anytime soon. And secondly, about the tax GDP ratio, I'll just add a few more points. Tax GDP ratio has improved. There is scope of it improving further, but the past decade has been the most amenable for an improvement of health spending, public health spending, because nobody really writes about it, but past decade India's defense spending as a proportion to GDP has come down considerably. I mean, normally people pit defense against health. India's defense spending has considerably come down as a proportion to its GDP. So that money that got free, where has it gone? It hasn't really come to health. It is improving. Slowly it is improving, but I mean, we haven't really seen it getting absorbed by the health sector. And secondly, the last few years, our fuel subsidies have been cut tremendously. A lot of resources have been free. We don't really see these fuel subsidies getting recycled into health subsidies, which is more progressive. So, I mean, the Niti Aayog says that in the next 2-3 years, the central spending on health is going to be doubled. This year, it has improved by 26%. I'm less hopeful given the past experience. In the 12th plan, the plan was to have 250,000 odd crores spent on health, but we ended up allocating only 46% of it. So I'm less optimistic on that front.
I see several hands up, and I have to ask the organizers. They wanted me to close the session at 7:45. So what is the instruction? 5 more minutes. Okay. So can we have a quick round of questions, and maybe then we can discuss it individually.
Just I like to some points which have not been addressed by the panelists. One is the important is the impact. Even though that the climate change is the important bargaining topic and the externalities, and it's surrounding it, the different disease vectors appears, like the heat waves, like the cardiovascular disease, like vector-borne diseases, etc., etc. So So the impact of the climate change, the related disease vectors, that should be addressed in these discussions. Second thing, I like one question to Sushma Kapoor, that she has rigidly defined that, pointed out that the current health system is not efficient. My question, what is the alternative?
The person in the back who would actually put her hand up first.
Hi, thank you. I would like to talk about antibiotics again. I'm sorry to jump back to that topic. It starts with a really brief anecdote. When I used to live in India, I didn't have any major illness, but they prescribed at the doctors, they gave me antibiotics 6 times in 1 year. And I would go there for fever or something, and they just, antibiotics. And I don't think it's just me, because 2 years ago, the Indian Medical Association sent out a statement asking doctors not to prescribe antibiotics for nothing. So I was wondering if we should address these issues to doctors as well, and to the way people who actually have money and go to the doctor, they still get antibiotics for common illnesses?
Yeah, I think it's a very good point you've made, because it's not just about people taking antibiotics, it is about, it's an unequal relationship, as we know. So, the doctor sets the standards for what is. So I will ask you, and then I'll come to you, because her hand was up much.
Some time ago, I read this piece of investigative journalism that reported on severe underreporting of malaria cases in Odisha. And so I want to ask, like, how prevalent is this in other disease areas, or in other health areas, and in other parts of the country? That's something. And also, since you talked about comprehensive healthcare, and we've talked about, and there was someone mentioned that right now healthcare focuses on maternal or child healthcare. So why is it that we only talk about women when they're mothers? What about reproductive health or menstrual health? Or
I work for the ADBI, Asia Development Bank Institute. I think I'd like to raise a question about the public finance. I think the 1% of GDP, the public finance is very too low. So, what you said, the tax buoyancy is high, and central government will increase the spending of the health, and the front workers are in shortage. I think so. The coordination between education policy and medical policy are important. Say train the doctors and nurses, and also I think the states are reluctant to allocate the resources to the medical care. Probably there is a divide between the poor, and so improve the health of the poor will not increase the productivity. You need also the employment, provide a good employment. So the coordination of the public finance will be very, very important, so I think.
Yeah, I'll just respond to the Odisha malaria related question. Numbers of all the vector-borne diseases in India are underreported. And about 5 years back, I mean, there was, it sometimes becomes a question of national pride, so the government suppresses it sometimes. Yeah, and 5 years back, there was a committee which revised the malaria mortality in India by about 20 times. And one more thing about Odisha, 9% of all the deaths in Odisha, I mean, this is government data, I don't quote any other data, 9% of all the deaths in Odisha are due to malaria. I haven't seen anybody write about it. The data came out 3 months back, but I haven't seen anybody writing about it yet. No, 9% of all the deaths.
I just want to add, I mean, since we've been talking about a system, the fact of the matter is that the vector-borne disease control program itself admits that only 30% of cases come to the public sector. So we are talking about a very large access to the private sector, which is unregulated. So, you know, there is underreporting. But there is also the fact is it's underreporting because there only such a small proportion are coming to your public sector. That's what gets reported as data.
I'm sorry, a very short question, which maybe is linked to what you're saying now. I have a curiosity. If the recent demonetization has had any visible effects on access to healthcare, or if you foresee it will have.
We'll only have anecdotal kind of evidence. We don't have any robust evidence, but we know if you look at the people who seek care, especially in the private sector, and our experience of those who are sitting around the table, you have to first make a down payment before they'll treat you. And then, of course, the bills will be, you know, you'll have to cover the costs of whatever happens. So even in emergencies, the behavior of the private sector is to first take money before they treat. So if you had demonetization, the anecdotal evidence seems to suggest that it led to denial of care. And it was a serious issue.
Just a closing comment, not associated with the demonetization. I actually worry about the plea for increasing public expenditure on health without a better understanding of efficiency of the health system. I think that somehow the fact that we have 70% out of people using private care is really a rejection of the public health system. It is not necessarily being pushed out. And that rejection is taking place because of some reason. And I think that accountability of the public system, also expenditure on some of those frontline workers, it's not at all clear to me what an ASHA does or what can do. Okay? Is it an employment generating scheme or is it really health promoting scheme? It's something again that needs to be evaluated. So I think instead of just making a plea that we must spend more, and of course we must, we also must demand simultaneously an accountability.
I think that's a good closing comment to make. I see that the next guest has already arrived. Sanjeev Sanyal is here. So if you don't mind, I will close the panel now, and I'm sure we can carry on the discussion maybe over dinner. Thank you. Thank you.